We have two lectures today. The first lecture is on centralized pain in rheumatic diseases, the invisible element. The lecture is done by Dr. Chiranthi Liyanage. She is a senior lecturer in pharmacology and also a consultant in rheumatology and rehabilitation, Faculty of Medicine, Colombo, University of Colombo. Over to you, Chiranthi.
Yeah. We'll have to put slideshow and then share. Slide. This whole screen won't show. It's okay. Okay. Good afternoon, everyone. So I thought of talking about centralized pain that we commonly see in rheumatic diseases because often we come across this situation. It is there, but we are not looking for it, and therefore we don't notice it. So even if it's glaring at our faces, even if it's like an elephant in this room, you might not pick it up unless we are looking for it. So let us take a common patient, a very common scenario we come across in our clinics. It's a sort of middle-aged female with seropositive rheumatoid arthritis, already diagnosed, on treatment, been on it for a few years, on methotrexate, sulfasalazine, and hydroxychloroquine, maximum doses with folic acid. No problems with the medication. She's been on it for a few years, but she's had this ongoing pain as well. So this time when you see in clinic, she's complaining of pain. You check her joints, about 13 joints are tender, but none of them seem particularly swollen. None of them seem particularly inflamed. Her inflammatory markers are essentially normal, and you go on to do a DAS28 because that's what we go by. We do an objective assessment of the disease severity. The patient says that her global health score is 80 out of 100, and you get a DAS score of 5.2. So that's severe disease. So what do we do now? Do we escalate DMARDs? To answer that question, we would first of all have to look at why is she in pain? Why is she having persistent pain while on treatment? And why is it not responding to whatever that we're giving? So in rheumatology, in the rheumatological diseases that we come across, be it inflammatory or mechanical, the acute pain occurs due to different reasons. It could be inflammation, where, like in rheumatoid arthritis or spondyloarthritis, where there's tissue inflammation, which leads to pain. Or else it could be due to tissue damage or a mechanical damage, like arising from articular or periarticular structures, like what we see in osteoarthritis. But sometimes, even with rheumatoid arthritis, there is a structural damage that happens that can lead to pain. Or else it could be due to ischemia, like in vasculitis or in Raynaud's, which leads to pain. Now, acute pain, this is something that we all know. There is some form of tissue injury through any of the mechanisms that I told you about earlier, and that leads to an inflammation, either primary or secondary to an initial insult. And with inflammation, there are so many mediators that are released, from substance P, prostaglandins to acetylcholine, and different cytokines that are present in blood. And these go and act on the nociceptors in our tissues, which activates them, generates an action potential, and that leads to a let's get the laser pointer, and that leads to an action potential that's transmitted to the first order neurons, synapses in the dorsal horn, process, and is transmitted up through the spinothalamic tract. And these relay in the thalamus and then conveyed to the cortex. So that's how we feel pain or perceive pain. So this is essentially, as I told you earlier, it's due to an inflammation or some form of damage. So this is what we call nociceptive pain or a nociceptive input. And this is often what we get as acute pain in rheumatic diseases. And traditionally, we define chronic pain as pain that has persisted for more than 3 months. So we tend to think that acute pain that lasts for more than 3 months is chronic pain. And traditionally, we have categorized them as either inflammatory or due to structural damage, like as I told you, like in rheumatoid arthritis or osteoarthritis, and this is what we call nociceptive pain, and neuropathic, what we all know about in diabetic neuropathy, radiculopathies, and anything that we can't explain by these mechanisms, we have traditionally thought that it's centralized pain. And these can't be explained. This is pain that cannot be explained by a peripheral source. So often we think of it as being psychogenic or psychosomatic, like fibromyalgia, irritable bowel syndrome. Okay? But when we really look at what happens in chronic pain, you will realize that it is actually more than acute pain lasting for 3 months, because it's much more complex and there are a combination of factors that interact with each other to lead to chronic pain. And we have all heard of something called neuroplasticity, and you would have come across it often when you're talking about strokes or spinal cord injuries. So that is when the nervous system adapts, or there are structural changes or changes in the neurotransmitters that happen due to an intrinsic or an extrinsic stimuli to reorganize itself, to change its response and its connections. So that is what we refer to as neuroplasticity. And through multiple studies, it has been found out that there is neuroplasticity that happens with pain. For example, at the level of the nociceptors, there is a lowering of the threshold of the nociceptors, so that stimuli at a lower threshold will elicit an action potential. And then at the level of the dorsal ganglia, there is modulation of pain that happens, and there is a change in the descending pathways that inhibit pain transmission. So this is what we call central sensitization. In addition to that, there are changes that have been found that happens in the brain from functional MRIs and many other studies. They have found that there is brain remodeling that happens with chronic pain. So these are changes that happen in the thalamus as well as the higher centers. So because of all this, there is an adaptive mechanism that later on becomes maladaptive when pain lasts for a longer period of time. So these changes, these neuroplastic changes, if you got the 4 things that happen, can either be top down or bottom up. So top down is coming from the higher centers down the descending pathway. So that can happen even without any peripheral pain. And there is a genetic predisposition to this kind of nociplasticity, and we often see it in primary fibromyalgias. The bottom up are changes that happen in ascending pathways. So this is what we usually see in secondary fibromyalgias, and it's often a combination of all these that happen in secondary fibromyalgias that we see in rheumatic diseases. In addition to that, there is thought to be an autoimmune mechanism that contribute to chronic pain in rheumatic diseases. There is autoantibody activated complement and innate immune system that leads to cytokine release that facilitates the peripheral sensitization. And there is also changes that happen due to these autoantibodies in the central sensitization. So in this, you can understand that acute pain becomes chronic pain through these maladaptive neuroplasticity, and there is a process of chronification where it lasts for a long period of time and it becomes chronic. So what essentially happens is that the central nervous system or your nervous system amplifies the nociceptive stimuli. So there is hypersensitivity to pain. Essentially, the body is turning up the volume of pain that you feel. So because of that, you get a hyperalgesia where it's a painful stimulus, but you feel pain much, much more than another person, or a stimulus that is not painful usually, can be painful. That is what we call Anodynia. So this amplification and hypersensitivity to pain is the feature of centralized pain. And there's this central pain prone phenotype that has been found from multiple studies looking at the risk factors. So generally, females are more prone to have centralized pain. There is a genetic predisposition. If there's a family history of chronic widespread pain, it could be there. If there's early trauma, and if the patient has other features like catastrophizing, that is when something is not as bad, they see it as the worst possible thing on earth, right? If they have such traits, again, they're more likely to have centralized pain. So when a person is prone to this and they get a stressor or an acute pain or a nociceptive input on top of that, that leads to these neuroplastic changes to happen and persist, and you get pain in different areas and you get new pain that lasts for a longer period of time. So there are different terms that are used for this, be it centralized pain, chronic widespread pain, nociplastic pain. All these things mean the same thing because the changes that we see are the same. And when we look at the general population, it depends on the different studies that are done. It's usually quite low in men, but it does happen. And the prevalence is much more in women. But when we compare the general population to those with rheumatic diseases, it's much, much more. About 30 to 60% of patients with rheumatic diseases have centralized pain as well. So as I told you, apart from being female and the genetic predisposition, other risk factors include lower socioeconomic status and other stressors in life and sedentary lifestyle as well. So now we know there is an elephant. You might say it, you might not, but why are we talking about this elephant? It's because of the impact of this centralized pain that has on the patient as well as on us and the healthcare system. So this sort of pain is a major determinant of patients' global health scores. And quite often, alleviating this pain is a top priority for the patient because that's what the patient feels. We are worried about disease control, but for the patient, the priority would be to get the pain under control. And it leads to a whole lot of other problems, including disturbed sleep, disturbed mood, depression, anxiety, and that limits their activities because of the fatigue and leads to disability abilities, and they lose work and income, and that can be to emergency departments, more hospitalization, and they're more likely to be on multiple medication, more likely to be on DBARs and opioids. So it predisposes to medicine overuse and irrational use as well. And for us, when patients have centralized pain, they will give a higher global health score, like the example that we took before, that will artificially inflate our composite disease activity measures, and that's invariably going to affect our decision making on further treatment, unless we really recognize. So, centralized pain, now the prototypic one that we know of is fibromyalgia, where you have widespread pain. There are localized forms like chronic low back pain, chronic temporomandibular disorders, chronic primary bladder pain syndromes, irritable bowel syndrome, tension headaches. All these are centralized pain syndromes. Now, we'll talk about widespread pain because that's what we often see in rheumatology, and that is, if you want to split hairs on whether to use centralized pain or chronic widespread pain, or to call them fibromyalgia, you can go on a debate all day. But practically speaking, when we look at chronic widespread pain, the definitions that have been used in prevalence studies are different from the classification criteria for fibromyalgia. That's why we see the difference in the prevalence. But essentially, the mechanisms underlying both so-called conditions are the same, and it's like two sides of a single coin, depending on what criteria that you use, depending on what parameters that you look at, and it's on a spectrum. If you use strict criteria for fibromyalgia, they all have chronic widespread pain, and you label them as fibromyalgia. And if you use just chronic widespread pain, you will have people who fall into the category of fibromyalgia as well. So these classification criteria, you must remember, are mainly for epidemiological studies and trials. And if you are not experienced enough to pick these up clinically, yes, they can be used. And there are multiple criteria that have been published from 1990 ACR criteria that says there has to be pain in 11 out of 18 sites. That was revised in 2010, 2011. Then this AAPT criteria came in 2013. Then the ACR criteria was revised in 2016. And we have the Royal College of Physicians criteria in 2022. So there are multiple criteria, but it is, practically speaking, it is really a clinical diagnosis. So what do we look at? In the history, they'll say that they have pain in multiple sites, widespread pain, or some call it generalized pain. And it has been there for a few months, at least 3 months. We won't go and label a person as having fibromyalgia or chronic widespread pain. If it has been there only for a week. And they have other problems. They can't sleep well. They feel fatigued. And along with that, they can have other features like cognitive impairment, poor memory. They can have headaches. It might be associated with other syndromes of centralized pain, like irritable bowel syndrome. They can have tension headaches. They can have temporomandibular pain. So these things would be there in the history. And when you examine, you can't detect any inflammation, so no warmth, redness, what we usually look at for inflammation, but there is widespread multi-site tenderness that is not particularly localized to a specific structure. Investigations in these patients will essentially be normal. And the sites that we look at, this was extracted from the 1990 publication of the ACR criteria, and this illustration is based on a painting by a French artist called Jean de Baptiste Renoir, the three graces. So you can see that the points will be both in the upper body and the lower body, and the left and the right. So you have multiple points, multiple sites that are widespread, that will be painful and tender. So when we are evaluating a patient, of course, we need to look at the joints, see if they are inflamed, look at the periarticular structures, the soft tissue, see if we can detect any localized pathology. And then we move on to examining for widespread pain. And of course, sometimes we will have to do a neurological examination as well. And this is from the 2022 RCP guidelines. Along with that, we need to think of other causes that can cause pain, including certain medication like statins or aromatase inhibitors. And we might have to we definitely have to look at other conditions that are associated, like sleep apnea, depression, anxiety. And sometimes we might have to carry out certain blood tests, including thyroid functions, in these patients to looking for a cause that could cause this presentation. However, you must remember that a diagnosis of fibromyalgia, if you make it clinically, it is valid irrespective of any other diagnosis that the patient has. For example, there are loads of patients with SLE with centralized pain. There are loads of patients with rheumatoid arthritis with centralized pain. So irrespective of any other diagnosis, a diagnosis of fibromyalgia is valid. If you go through the previous classification criteria, it says that the pain cannot be explained by any other cause. If there's no other explanation, you go for a diagnosis of fibromyalgia, but that has gone out now. Even a person who has other reasons which could cause pain can have fibromyalgia. And the other important thing to remember is, just because a person has a label of fibromyalgia or you make a diagnosis of fibromyalgia, it does not exclude another clinically important illness. So that is very important. Just because a patient who comes with a label of fibromyalgia, if they get new symptoms, if there's worsening of symptoms, you must first of all exclude other clinically important illnesses that could account for that presentation. So coming back to our patient, when you examine, you find multiple tender points, both in the upper and the lower body, and on the right and the left side. She says she can't sleep well, she doesn't feel refreshed when waking up from sleep, and she feels fatigued throughout the day. And although she has these tender joints, because she doesn't have active rheumatoid arthritis clinically, we came to the diagnosis of fibromyalgia. So what can we do for this patient? Now, when it comes to treating fibromyalgia, our aims are to reduce these symptoms, reduce the pain, reduce the fatigue, reduce the insomnia. So essentially, we need to recognize these problems in a timely way, and we'll have to individualize the management based on patient's predominant concerns. And we quite often need a multidisciplinary approach, and patient education is also of paramount importance. And we might have to use, in addition to medicines, we will need other non-pharmacological methods, and recognizing and treating the underlying rheumatologic conditions will improve the outcomes and improve the pain. So if we recognize them early, if we start treatment early, and if we treat this rheumatological conditions that the patients have, which will essentially stop the down-up neuroplasticity changes that happen that can prevent the chronification of pain. So to do that, you will have to look out for patients who could be having centralized pain. For example, if they complain of widespread pain and there's intrusive fatigue, they don't want to be fatigued, but they do feel fatigued. And they're saying that they don't feel refreshed after waking up. There's hypersensitivity. There's a long duration of symptoms. The treatment don't seem to work. They feel overwhelmed. They can't concentrate. If you pick any of these up, you need to think of it, look out for it, and evaluate these patients properly. So coming on to how do we treat them? Often, if it's very mild, they might not need medication. But you all know how many of our patients are compliant with exercise or diet or healthy lifestyle. So these measures, we do advise them, but it might not really, they might not adhere to it. So often we do start them on some medication. So things that have been found to be effective, tricyclics, mainly amitriptyline. Cyclobenzaprine is sort of out of use. We don't really mainly. And of the anti-epileptics, the evidence is for Pregabaline and gabapentin. There is very limited efficacy with analgesics, paracetamol, NSAIDs, or opioids. The other ones that we often sort of see being used are SSRIs like fluoxetine, citalopram, and paroxetine. There is evidence for it. There is some evidence for it, but those are fairly smaller trials compared to the SNRIs. And when we're starting treatment, we need to start at a low dose and gradually increase to pump them up to a therapeutic dose. And again, we have to remember that these medicines will take some time to act. It will take about 2 to 3 weeks for them to see a clinically effective benefit from it. And we need to give it some time to see whether it's working. So give it at least 3 months to see if one is working. If not, you can switch on to a different class and see. And what are we basing these recommendations on? There are randomized control trials. However, the numbers are quite small, and there are multiple reviews and meta-analysis, including Cochrane reviews, although they have been done a few years ago, in 2015, 16, 17. But if you look at the effect of amitriptyline, to get at least a 50% reduction in pain, the number needed to treat is around 4. So you all know to prevent a fatal MI with aspirin, the number needed to treat is about 77. So these do work. There is evidence for us to use this, and pain is a very debilitating symptom for patients. So the same with duloxetine. Usually doses you start around 20 to 30 and build up, keep them around 60 if they're tolerating. Again, the number needed to treat is about 8 to get about more than 50% benefit of pain. Pregabaline, again, it's around 5, the number needed to treat. And here, what they have looked at is at least a 30% reduction in pain, but that is still an improvement. So different guidelines on managing fibromyalgia gives different sort of strengths of recommendation depending on what methods that they have used and what they have looked at. So for EULA 2017 guideline gives a weak recommendation for all this, including tramadol, which is the other ones are strongly against or have not made any recommendation for tramadol or other opioid analgesics. We would advise against it because it has a lot of side effects. There are problems of dependency. and the efficacy is quite low. But others, tricyclic antidepressants, SNRIs like duloxetine, and antiepileptics, Pregabaline and gabapentin, if you can't get a hold of Pregabaline, are actually very good choices for patients with centralized pain. But here, just like us, our patients will also go and Google what you have prescribed. And the first thing that they will see is that this is, if you have given an amitriptyline or duloxetine, is that it's an antidepressant. So first thing would be to tell them that these medicines are used to treat depression, but it does work for the pain that you have. We are not treating you for depression because that label of depression carries stigma, and patients' compliance will depend on the advice that you give them. And the other thing is to tell them that it might take a little time to act. Give it a couple of weeks, and then we'll see how you're doing. So, apart from pharmacotherapy, exercise is the other thing that has a lot of evidence, or even at least a moderate level of evidence, to support in the use of treatment of centralized pain or fibromyalgia. So EULA actually makes a strong recommendation for using exercise therapy, and it has been shown to decrease pain and to improve function. So when you exercise, we all know that there is a release of endogenous opioids. So those go and act on the opioid receptors, and that's thought to modulate the analgesic effect of exercise. And usually what we advise is to engage in exercises that can improve your cardiovascular fitness, and to use low impact ones like brisk walking or swimming or cycling, and or as water aerobics if they do have access to that. And certain other things like yoga, tai chi, there are people who do practice this. So these ones have also been shown to reduce pain in centralized pain. But you have to tell them that if you've been sedentary all your life and you go and start working out rigorously, that can actually worsen your fatigue. And initially, a lot of these patients, as they start, they might feel more fatigued. So it has to be a gradual incrementation of duration and intensity. And you have to warn them of the initial fatigue that they might experience. And we do all this, and if there's still no response, number one, we have to make sure that they are compliant with whatever that we have given them. And we have to look for any other causes that could be perpetuating this cycle of pain. And if monotherapy doesn't work, there is a place for combinations. And we need to remember not to combine 2 tricyclics or 2 SNRIs. So if the patient's already on amitriptyline, there is a place to add either an SSRI or an SNRI in the morning. Or else if they're on something like Pregabaline in the night, again, we can add a low-dose SNRI in the morning. And if they're not responding at all, we need to consider referring them for psychotherapies and getting the psychiatrist or the psychologist involved. And if we do have access to a formal exercise program, by all means, we should get them engaged. So psychological therapies, again, they can improve function and improve mood, and it has to be individualized. So different therapies have been used, including cognitive behavior therapy. If they're into meditation and mindfulness, you can use mindfulness-based techniques, relaxation. So there are different things that have been used. Other things, so vitamin D treatment, if a patient's already vitamin D deficient, treating them will improve pain. But there is no evidence to say if they are not deficient, vitamin D treatment actually improves pain. So if they're found to be deficient, yes, by all means, treat them. That will improve their pain. Complementary therapies, there is some evidence for it, so we won't if they're engaging it, as long as it's not harmful, we won't say no. The other things, including transcranial stimulation or TENS, these have been trialed and have been found to show some benefits, some improvement. So basically, our approach is based on the patient's predominant concern. If it's predominantly pain, advise them about exercise, get them into engaging in something that they can and they enjoy, and start them on some treatment, either TCA or an SNRI or something like Pregabaline for the pain. If it's mainly fatigue, again, exercise will definitely help. Get them to manage their sleep, advise them on sleep hygiene. Cognitive behavior therapy and other things might help. And SNRIs more than tricyclics, because tricyclics can also make you more drowsy, make you feel a little bit fatigued at the end of the day. It's poor sleep hygiene, obviously, but from the treatment options that we have, we prefer something like a tricyclic or Pregabaline and Gabapentin. If it's mood, SNRIs would be preferred over Pregabaline or tricyclics. But patient education is actually really important. That's one of the things that we often don't do, but it is extremely important, because these patients have ongoing pain. Quite often, by the time they come to you, they would have been told there's nothing wrong with you. So they don't know what's wrong, but they do feel this pain. It's real. So you will have to someone will have to spend a little bit of time and tell them that this is a real illness. It is because of certain changes that happen in your nervous system, and you are feeling this pain. Because by that time, a lot of the patients would have been told that it's probably in their head, it's psychogenic. You need to validate what they feel. And you need to also tell them the role that stress and mood plays in the pain that they feel. Help them engage in relaxation techniques. Talk about catastrophizing, about how they think that there's something terribly wrong, but it's not that there's something terribly wrong. We know what's going on, and there are things that we can do to try and help. And you have to talk about prognosis. This is a disease. It is really a disease that waxes and wanes with the external stressors, with other nociceptive stimuli. The pain that they feel will wax and wane. So it's not going to be static, but there are a lot of things that they can do to manage that pain, and there are things that you as a clinician can also do. So it's very important to have that conversation with these patients. But by now, judging by your faces also, I know you're thinking, this is what our clinics look like. How on earth are we going to do all this? And that is where we need to consider training other staff. Maybe have nurse-led services. Maybe have leaflets for the educational programs for these patients. If we have dedicated, we do have pain clinics, but I'm honestly not entirely sure on how geared they are to managing centralized pain. So we need to think of all this and think of a way forward where we can manage our workload and also do justice to these patients. So in summary, centralized pain is actually very common among patients with rheumatological diseases. And before we consider escalating DMARD therapy, we need to consider the possibility of centralized pain and recognize it. And a diagnosis of centralized pain is valid if you make it properly. It's valid irrespective of whatever other disease the patient may be having. But remember, that label does not mean any other clinically important diseases are also excluded. So we need to recognize it early, start treatment early, and quite often it will need a multidisciplinary, multimodal approach, and patient education is crucial. So unless we look at these patients holistically. We look at the whole patient and take a bit of time. Like in the case that I spoke to you about, one person might palpate the shoulder, think that it's a bicipital tendinitis. Another person might palpate around the knee and say, oh, this lady has ancillary bursitis because that's tenderness there. Another one might palpate the joints and say, oh, this is a rheumatoid arthritis flare. So we can be misled unless we look at the patient in total. So to see the elephant, you need to look at the whole patient. You might need to spend a little bit of time, but you need to look at the patient as a whole. Thank you.
Thank you very much, Chiranthi, for that very interesting presentation. Any questions from the audience? Likely. Diagnosis and management and asking questions about fibromyalgia, all difficult, confusing. Right, so shall we move on to the next lecture done by Dr. Ranasinghe. It's on a case discussion, an unusual cause of sacroiliitis. Nadika is a senior registrar in Rheumatology and Rehabilitation attached to Colombo South Teaching Hospital.
Good afternoon, Carol. First of all, I would like to thank the College of Specialists in Rheumatology and Rehabilitation for giving me this opportunity to share my clinical experience with you all. I would like to bring a case of uncommon cause of sacroiliitis, followed by my presentation. So the patient concerned was a 32-year-old male, unmarried, with a well-built physique from Ottawa. He was employed as a driver in a private company without any significant past medical history. He presented to us with right-sided buttock pain lasting for more than 1.5 months duration. That pain has started off as a dull pain and gradually progressed. There was no radiation of pain to the lower limbs. Pain was worse during the morning. It got worsened with activities like walking and running too. He said that there was restriction of movements felt while bending to the right side, but there were no neurological features felt in lower limbs like numbness or weakness. It was not associated with fever, but he complained of loss of appetite over the last 4 weeks with sensation of loss of weight. Weight was not measured, however. There was no history of trauma, no upper back pain or neck pain with restricted movements. He denied involvement of other peripheral joints. There were no painful swelling, no history of painful swelling of fingers, and no features of enthesitis. And there was no involvement of eye suggestive of uveitis. There was no skin rash or nail changes, scalp lesions suggestive of psoriasis. Patient denied chronic diarrhea with mucus or blood. And even though he had loss of appetite and loss of weight after the pain, His cancer screening questions could not reveal any positive finding. Patient could not recall any episode of upper respiratory tract infection or gastrointestinal infection preceding to this illness. At that moment, he didn't have any features suggestive of conjunctivitis or urethritis either. The patient did not complain of having any chronic cough or having a contact history of TB or past history of TB. And he denied any history of consuming unpasteurized dairy products under milk, and there was no history of working in a poultry farm either. In the family history, we got to know that mother had knee arthritis at the age of 56, but it was probably osteoarthritis. Other than that, there was no disabling arthritis involving any other joints or spine noted. There was no skin diseases running through the family like psoriasis or gastrointestinal diseases like inflammatory bowel disease. As I told you, he was working as a driver for a private company. He had to drive mainly the heavy vehicles, lorries, and sometimes the vans. He was unable to continue work. He has been on leave for the past 2 weeks. So in the examination, there was an obvious limp in the stridor on the right side. But however, the cervical spine and the thoracic spine examination was found to be normal. Cervical spine range of movements were normal, non-tender. Wall to tragus test was 9 centimeters, which is within the normal range. Thoracic spine was also non-tender, and the chest expansion difference between forced expiration and inspiration was also 3 centimeters within the normal range. But in the lumbar spine examination, we had some significant findings. The forward flexion was restricted, apparently. Modified shoulder test showed only 3 centimeters, which was significant. And the lateral spinal flexion test, on the left side, it was normal. It was 12 centimeters. On the right side, it was 7 centimeters, which was significant. Intermalleolar distance while standing with legs separated was again significant, was less than 100. It was 94 centimeters. However, there was no lumbar spine tenderness, but we could elicit a significant right-sided sacroiliac joint tenderness, but the left side SI joint was non-tender. Straight leg raising tests were also found to be negative. Peripheral joints, we didn't find any features of inflammation there. They were non-tender and not swollen. There were no features to suggest dactylitis or enthesitis, and there were no skin or scalp lesions, nail changes suggestive of psoriasis. And he didn't have features of uveitis either. So we moved on to the investigation. Basic investigations showed leukocytosis with a neutrophil predominance, and there was marginally elevated platelet counts. And he had high inflammatory markers from the beginning, and ESR was in the 80s, and CRP was close to 50. HLA-B287 we tested, it came as negative. So we moved on to the basic imaging modality, which showed, and got it reported also. It showed us a sclerosed right side SI joint with a straight spine. So at this point, it looked like a fairly straightforward case. His disease activity scores like BUS-DI was found to be around 6, which meant active disease, as does ankylosing spondylitis disease activity score was found to be high as well, which meant very high disease activity, and his functional index BUS-3 score was also high, which meant high functional impairment. So this looked like a straightforward case at the beginning, and we started off with the NSAID regime, indomethacin with a gastric protection. We gave him for 2 weeks and reassessed, but the activity scores, like you say, had very little change even after 2 weeks. And the inflammatory markers were also had a very minute changes, with ESRB still being 82 and CRP at 41. So we changed on to a more potent NSA. In approximately 512 hour was given for 3 weeks with the gastric protection cover. And we reviewed him again, but still the disease activity scores were high. And the ESR was also remaining at the ESR-CRP were also remaining at the same level. So before starting treating him with DMARDs or biological agents, we thought of getting an MRI in the lumbosacral spine and sacroiliitis joints. As you can see here, there was high signal intake over the right SI joint, and not only that, the reporting of the MRI came with another finding, which was microabscess formation. So high signal intake at the right SI joint plus microabscess formation. Some of these abscesses extended to gluteus maximus too. So sacroiliitis was of infective origin. So at this point, we thought that we knew that we are missing something. So we went back in the history to ask him whatever we have missed. Upon further questioning, he disclosed that he was in prison for a year and released about 3 months ago. He had been sharing cell with some inmates and denied any IV drug abuse or unprotected sexual practices. But this alarmed us. Serial blood cultures were done. They came as negative. HIV-1 and 2 antibodies were negative. VDR non-reactive. Unfortunately, brucellosis antibodies we were not able to do. Ultrasound abdomen didn't reveal any intra-abdominal abscesses. Until we reached this definitive diagnosis, we started in of IV flucloxacillin, and the TB screening was initiated. As you can see, he had mild left-sided pleural effusion, which we could not elicit clinically. The sputum FP3 samples came as negative. We wanted to do a CT-guided aspiration because they had micro abscesses. Therefore, we wanted to get a CT-guided aspiration of the right sacroiliic joint with the help of the interventional radiologists, which unfortunately was failed. But the MAN2 test came as marginally positive at 10 millimeters. And TB-PCR, gene expert studies on sputum, came as positive. So we liaised with the chest disease clinic team and diagnosis. After discussing with them, we made as extrapulmonary TB with TB sacroiliitis. He was prescribed anti-TB drugs with a plan of continuing for 9 months. Should we have started steroids too to prevent complications of the SI joint later on? There were no evidence to suggest steroids were indicated, and both the rheumatology and chest clinic teams had opinions against steroids. After 3 months of anti-TB treatment, when we reviewed him, he had significant clinical and biochemical improvement. Both activity scores have come down significantly. And also the inflammatory markers, ESR being in the 36 and CRP at 10. At this moment, he is at the latter stages of the anti-TB therapy, and he has improved significantly and is now able to carry out his day-to-day activities without any functional impairment. So we manage this patient as TB sacroiliitis, which brings to my presentation musculoskeletal involvement of TB as in a rheumatological point of view. So rheumatology and musculoskeletal TB is not a new thing. It actually runs back way back into several thousand years, into the ancient history. Some archaeologists have found that there are evidence of TB in the ancient skeletal remains and even in Egyptian mummies. Likes of Hippocrates have suggested hinted about infection going on with the vertebra, even though they didn't know about a typical bacilli. It was Sir Percival Pott who described the pathophysiology of an infection occurring in a vertebral TB, leading to its destruction, causing neurological complications like paraplegia. But it was in 1882 that when Robert Koch found the tubercle bacillus, the real link was made between the Pott's disease and the organism. The association of TB and musculoskeletal or rheumatological disease is bidirectional. Why I say that is because TB can cause rheumatological diseases, musculoskeletal diseases, which is I'm going to talk today, and the vice versa also true. I mean, some of the rheumatological diseases can make one more prone to TB, maybe due to the immunosuppression of the disease, due to the disease, or immunosuppression due to the drugs, or some rheumatological diseases may cause permanent damage to the lung parenchyma. So thereby making one more prone for TB. So the prevalence is around now 10% of extrapulmonary TB in USA and around 10 to 35 of extrapulmonary TB worldwide is musculoskeletal TB. And if you consider all cases, all TB cases worldwide, at least 1 to 2% will have some sort of musculoskeletal involvement. It's actually the third most common site of extrapulmonary TB after pleural and lymphatic disease. So some interesting observations have been made in countries where TB is endemic, like ours. Most commonly affected with musculoskeletal TB are older children and young adults. But in developed countries, it's quite often seen in old persons. Even though pulmonary TB, we all know that pulmonary TB, extrapulmonary TB are more common in HIV patients. But musculoskeletal TB, we haven't found that there is any significant relationship or correlation with HIV positive patients. It can be the musculoskeletal TB can be the presenting symptoms of TB, and there may not be a concomitant pulmonary involvement. They are often confused with malignancy. So therefore, because of these reasons, diagnosis is often delayed, and as a result, it can lead to very poor outcomes. So there are a few mechanisms that involved in musculoskeletal TB. It's the first and main one is direct invasion of musculoskeletal structures, and the second one, inflammatory mechanism, and anti-TB drug-induced musculoskeletal diseases and other mechanisms. So first, the direct invasion, usually as a result, because as a result of hematogenous spread, but can occur via lymphatic spread also. And thirdly, as spread from contiguous focals. As in pulmonary or as in pulmonary TB, this also will heal with fibrous scar tissue formation and calcification. So this is a study done in 1990s actually in USA. They have analyzed the anatomical sites of musculoskeletal TB involvement. As you all can see, in the spine, most commonly affected are the thoracic and lumbar regions. In the peripheral joints, most commonly affected are the hips and knees. So these are the disease following direct invasions, Pott's disease, which we commonly call the tuberculous spondylitis, tuberculous osteomyelitis, tuberculous arthritis, tuberculous tenosynovitis, and tuberculous sacroiliitis, and myositis, and abscesses in muscles like psoas abscess. Tubercular spondylitis is the commonest manifestation of musculoskeletal TB. About 50% of the musculoskeletal TB are POTS disease. Most frequently, as I told you, is involves thoracic and lumbar vertebrae. Thoracic involvement is the commonest involvement, and it has characteristic involvement of anterior portion of the vertebra, sparing the posterior components. So the clinical features are mainly, the main clinical feature is a non-specific backache, so which can lead to delay in diagnosis. One study has shown that there is median of 4 months delay in diagnosing because of this non-specific nature. It can be associated with constitutional symptoms, weight loss, fever, and night sweats as well. But as the disease progresses, there can be, as disease become more prominent, kyphosis will occur due to collapse of anterior spinal ligaments, giving rise to a characteristic hunchback appearance called Ebers deformity. And there can be neurological deficits and sinus tract formation into the skin, and there are cold abscesses forming because of the spread of the infection to the surrounding structures like paraspinal tissues, psoas muscle, and if the psoas abscess is large enough, it may protrude under the inguinal ligament as well. On physical examination, there can be local tenderness of the spinal processes and back muscle spasm due to the pain. However, on the exterior aspect, signs of inflammation are usually not seen because, as I told you, the characteristically, this it involves the anterior portions of the vertebrae. So when we examine behind the back to the exterior aspect, we may not find form erythema, fluctuations, and other signs of inflammation. So range of movement test may produce severe pain, and neurological symptoms initially very subtle, like numbness and tingling. And as the disease progresses, it can present with the more severe complications like spinal cord compression. And later on, extrinsic cord compression can also occur. And those presenting with complete motor loss are likely to recover neurologically. Rarely, the cervical vertebrae can be involved. If the case is such, then the neurological complications will occur quicker than in thoracic or lumbar spine involvement. Retropharyngeal abscess formation is also seen, and torticollis, dysphagia, hoarseness, and cranial nervosis may also be seen in cervical vertebrae involvement. So investigations, we usually start off with the plain radiographs, but you need to have at least 30 to 50% vertebrae damage to see it from the plain radiographs. So it's fairly insensitive diagnostic tool. This is what it looks like, but I don't know whether this is very clear. As you all can see, multiple consecutive vertebrae are involved, and there is anterior destruction of the vertebrae with anterior vision. So radiographic characteristic of spondylitis are multiple consecutive vertebrae involvement and lytic destruction of anterior portion of vertebral bodies, displaced narrowing, vertebral osteoporosis, increased anterior wedging, and also collapse of vertebral bodies. Sometimes you might see the paravertebral shadow of an abscess or an enlarged psoas muscle shadow suggestive of psoas abscess. So obviously CSTH is superior and useful in determining the extent of soft tissue involvement like abscesses, sinus tracts, and soft tissue calcification. And sometimes you can use it as a guidance to get a percutaneous drainage done or biopsy done. But MRI is the imaging modality of choice. Detects early marrow and paraffin changes. And but if you are suspecting impending cord compression, then MRI should be done early on, very early, because it can detect intraspinal extension, focal myopathy, and in spinal cord or nerve root compression. So we move to typical osteomyelitis, usually in the metaphysis of long bones, femur and humerus, but can be seen in ribs, pelvis, in skull, and mastoid and mandible too. Can occur in conjunction with typical arthritis. When the lesions are multiple, we have to suggest an immunocompromised state too. So when the lesions are multiple, it can be misdiagnosed as a malignant process because we might think that this is metastasis, and sometimes we may have bacterial superinfection, coexisting Staphylococcus aureus infection with TB. Again, this will provide challenges to diagnosis. And clinical features are usually pain and swelling adjacent to the bone with the eventual limitation of movement. Runs a fairly indolent course where maybe even 6 to 24 months before the diagnosis. And the constitutional symptoms are often seen, and sometimes abscesses and sinus tracts may occur, but that is later in the disease. According to site of the involvement, there can be specific complaints, like if the typical involvement of skull occurs, then headaches and soft tissue masses can be felt around the head, around the skull. And if it occurs around the ribs and sternum, chest pain can become, the patient may come with chest pain, and the temporomandibular joint involvement will cause TMJ pain, chronic TMJ pain. Diagnosis, as I told earlier, if the lesions are multiple and lytic, so can be confused with malignancy. Plain radiograph will show lytic and sclerotic lesions, and periostitis can be seen. Even cystic lesions can be seen in children. Like in any other musculoskeletal TB, MRI can detect early changes in osteomyelitis too. So this is osteomyelitis of tibia, presenting as a lytic lesions there. And tuberculous lesions are rarely seen in the hands and feet. However, tuberculous dactylitis occurring in children is a well-recognized entity. There's a typical radiologic appearance, given a name given as spina ventosa, a ballooned out appearance is seen here. So this is a well-recognized entity, tuberculous dactylitis. Typical arthritis usually occurs as a monoarthritis 90% of the time. So around the weight-bearing joints like knee, hip, or ankle, it can be a very erosive, deforming arthritis, but slowly progressive, characterized by painful boggy swelling caused by synovial hypertrophy. And there can be restriction of movements due to pain. If the disease go untreated, then as late complications, as late sequelae, there can be ankylosing of the joint, deformities, and abscesses and sinus tract formation to the skin. And like in we got KL grading system in osteoarthritis of knees. Likewise, here in tuberculous arthritis also there's staging system in the according to the radiographic appearance of the X-rays. Stage 1 being no bony lesion, so and localized osteoporosis only. Stage 4 having gross anatomic disorganization. Again, CT will show bony destructions and soft tissue swelling, and MRI will detect earlier changes like synovial thickening and periarticular soft tissue changes. Synovial fluid analysis in tuberculous arthritis is initially it's xanthochromic, but as the time goes on, it becomes yellowish white, thick and gelatinous because of the debris. Joint fluid analysis will show usually will show high protein level, more than 2.5 grams per deciliter, and sugar level, low sugar levels, 40 milligram less than blood sugar, and WBC around average 10,000 to 20,000. But these are not specific for the tuberculous arthritis. These changes can be found in rheumatoid arthritis too. So therefore, every attempt should be made to establish a microbiological diagnosis. You can do a AFB staining of the synovial fluid, but the sensitivity is low, but it is considered to be higher than that's seen in pleural, pericardial, and peritoneal fluid. Best is to do a synovial biopsy and TB culture, which has a higher diagnostic yield. This is tuberculous arthritis, X-ray of tuberculous arthritis. And tuberculous tenosynovitis is an unusual manifestation, may occur in conjunction with another form of skeletal TB. Usually patient presents with the features of carpal tunnel syndromes like intrapulmonary neuropathies. Median nerve is here compressed underneath the flexor retinaculum due to the thickening of edematous tendon sheets. So there can be obviously there can be a delay in diagnosis in these patients because we don't suspect an infective cause usually in a carpal tunnel syndrome. The patient can present with the usual signs of numbness and tingling of the fingers, but at the same time, the patient will have swelling followed by wrist pain with decreased range of movements. So this will help somewhat to differentiate from the other causes of carpal tunnel syndrome. So sacroiliitis, tuberculous sacroiliitis, which my patient had, it's an uncommon occurrence. Less than 10% of musculoskeletal TB are tuberculous sacroiliitis. Presentation is buttock pain, which worsens with walking, sitting, and physical activity. There will be tenderness over SI joint, and sometimes SLRT may be positive due to irritation of lumbosacral plexus. Diagnostic delay may occur, obviously, because there is presence like inflammatory sacroiliitis. And X-ray obviously will show haziness of SI joint, like in ankylosing spondylitis. So joint space widening, sclerosis of margins will occur later. CT scan will show joint space widening and sequestration more clearly than earlier, but the MRI will detect the capsular distension and bone edema and destruction very early. Diagnostic aspiration and or biopsy is appropriate, which we couldn't do in our patient with a failed attempt, but it's appropriate to do a biopsy or aspiration to get a microbiological or histological diagnosis. So tuberculous myositis and muscle abscess. Myositis is usually found secondary to another musculoskeletal TB, and abscess formation usually we see in psoas muscle along with vertebral TB, like in Pott's disease. So if by primary myositis occurs without any other musculoskeletal TB, then we have to suspect another immunocompromised cause. Usual symptoms are focal muscle pain, swelling, tenderness, and weakness. Commonest muscle abscess formation in TB, psoas abscess formation. There is a clinical triad which presents when the patient presents with fever, limping, and backache. We have to suspect a psoas abscess. Sometimes palpable, when the psoas abscess is large enough, a palpable mass can be felt in the inguinal region of groin. And there are specific tests to test the tense psoas muscle, positive psoas sign, which is passive extension of hip on the affected side, while lying on the non-affected side, producing pain. And also hip extension against the resistance, producing pain. So again, X-ray will show calcifications or psoas muscle abscess shadows. Calcified psoas muscle is pathognomonic of a tuberculous abscess. CT will define tumor-like lesion, hypodense or isodense, and MRI will show a distinct mass. So CT MRI cannot really differentiate tuberculous myositis when there are no abscesses. Therefore, important to go for a definitive diagnosis with a histologic microbiological studies. So I have talked about direct invasion of muscular structures, and now I move to inflammatory mechanism. Mainly, I want to talk about the concert disease. Concert disease is a reactive arthritis without evidence of active TB in the joints. An acute symmetrical polyarthritis is involving small and large joints is the usual presentation. Usually occurs in extrapulmonary disease, but can occur in pulmonary TB too. If we consider the involvement of joints, commonly presents with oligoarthritis, 48%, and around 27% polyarthritis, and around 24% will come with monoarthritis. Most commonly affected joints are ankles and knees, with 63% and 58% respectively. And the commonly affected small joints are wrists and elbows. It can be associated with fever and erythema nodosum too. Sometimes Ponset disease may be the presenting symptom of can present before the diagnosis of TB. So, which we have to keep in mind. There is a lack of involvement of axial skeleton, which is a feature in this Ponset disease. And there is no chronicity or articular sequelae like deformities. This is usually considered as a monophasic disease, but rarely a recurrence can occur in the following weeks. Complete resolution occurs with 2 months of anti-TB therapy. If we need symptomatic therapy, we can treat the patient with the NSAIDs or steroids too. So erythema nodosum, we all know that this can occur as a part of Ponset's disease or as a separate entity in TB. Erythema induratum, which is an immune-mediated hypersensitivity reaction to tuberculous bacilli, frequently seen in adult females and commonly on the posterior aspect of the legs. And it will also improve with anti-TB therapy. And because TB is a chronic inflammation, there's a risk of developing secondary amyloidosis too, due to the accumulation of serum amyloid A protein. So they will present with signs of amyloidosis like polyarthralgia, intracranial neuropathies, and proteinuria. I move on to the third mechanism, anti-TB drug-induced mechanism. Mainly the drug-induced lupus is an anti-TB drug-induced musculoskeletal disease due to isoniazid commonly, and sometimes because of rifampicin too. Usually involves the musculoskeletal system, and polyarthralgia can be seen, and serositis with fever. Usually there are no internal organ complications in this context. It usually occurs with more than 1 month of exposure to the drug, isoniazid or rifampicin, and resolves with drug withdrawal. There are polyarthralgia and tendinopathy reported due to rifampicin and quinolones as well. And gout is a common occurrence with the use of pyrazinamide, because pyrazinamide interferes with renal excretion of urate, which leads to hyperuricemia. So gout can occur when you are treating patient with pyrazinamide. So we move on to the last mechanism, unknown mechanism, secondary fibromyalgia. And it's very common in rheumatological diseases. We all know that it's due to triggering of abnormal pain signaling in the pain pathways. Likewise, in chronic infections also, due to chronic inflammation and infection, like in TB, fibromyalgia can occur. One study has found that about 21% of active TB patients having fibromyalgia. So I wanted to provide you some take-home messages here. In musculoskeletal TB, radiological evidence may suggest a diagnosis of TB, but bacteriological or histological confirmation is required to prove the diagnosis. That is the ideal situation. But in our country, there may be a lot of situations where this is not always possible. In developing countries like ours, where TB is highly endemic and resources are limited, then diagnosis of musculoskeletal TB is often based on clinical judgment and radiological findings. So we'll have to take a rational decision using our clinical judgment and radiological findings. And early diagnosis and initiation of appropriate TB will prevent loss of function and mobility. And the TB regime is usually 6 to 9 months. Sometimes surgical therapy may be needed in refractory diseases. Surgical therapies like debridement may be needed in refractory diseases. Concomitant use of corticosteroids is not recommended unless there is evidence of tuberculous meningitis or cord conversion. And our target is to go for a full restoration of function without deformity. So that should be our target, full restoration of function without deformity. But earlier there was satisfaction with achievement of simple survival of the patient in a moderately disabled condition, but that is no longer acceptable or encouraged. We have to go for the full restoration of function without deformity. So these are my references. Thank you.
Thank you, Nadika. Any questions from the audience?
Yes. More common is the unilateral one. More common is the unilateral one. I haven't come across any bilateral sacroiliitis in the not yet.
So it's like easy to meet.
Yeah.
But when you are unilateral sacroiliitis, always better to do imaging and confirm and other things. So it's related pulmonary TB as well.
No, only pleural effusion, madam, taken as the extrapulmonary TB, no lung parenchyma.
The next one, possibly symptoms.
Yeah, spirit.
Pulmonary TB.
That's right. Yes.
I think so. It's not possible to aspirate and do biopsy.
Yeah.
But in other sites, what the histopathology saying is it's not easy to mix when you know what it is with TB.
Yeah.
So synovial biopsy, it is possible always to get that synovial biopsy in our institution, they don't like to start editing without the synovial biopsy. But of course, if they take not any place to activate or do biopsy. But otherwise, thank you.
Thank
Very good. Yeah.
He was planning for 9 months, madam.
9
months.
Finally,
Yeah.
it's like 9 months.
9 months.
Okay, very good.
One just if it is if the mechanism is immune mediated, then this is directimation.
Yeah.
So the duration is you can get pulmonary TB and Ponce disease. No? Then it's the same duration.
Ponce disease, madam? Yeah. No.
No, I mean now the infection is in the lung and you get joint involvement due to Ponce disease.
Same duration.
Same duration as pulmonary.
Yes.
And any what is the base of ADA, Anderson, diagnosis of musculoskeletal TB?
Musculoskeletal TB, madam, usually in tuberculous arthritis, the site
Maybe in the
of
pulmonary effusions.
Yeah.
Any place for musculoskeletal?
They mentioned about
I'm thinking less sensitive.
this.
Okay, thank you very
Thank
much. Thank you all, and we will meet in 1 month's time in the first Friday of September.